In this small video, we will show some real-life application of intraoperative OCT for macular surgery. This case is of a 60-year-old female with 2150 best corrected visual acuity, phakic, and a primary full-thickness macular hole, in which you can see the OCT shows some strong adhesions to the RPE and flat edges. After an uneventful cataract surgery, 23-gauge cannulas are placed and core vitrectomy started in standard fashion. Since the beginning of the case, it seemed to be that there was a complete PVD. Nevertheless, we rechecked by doing high vacuum around the optic nerve and arcades. Intraoperative OCTs allow us to recheck if we can identify any sign of persistent hyaloid adhesion at the optic nerve head. Additionally, in the same maneuver, we can visualize the macular hole with flat edges as initially suspected. With the help of ICG staining to enhance visualization and using a macular fat lens, we proceed to initiate a linear ILM tear that will allow us to create an ILM flap or rug, which the plan is to stay hinged nasally and cover the macular hole. As the ILM flap creation continues and we get close to the temporal edge of the hole, we use the intraoperative OCT to allow us to identify if the edges of the hole are being lifted and the adhesion is being liberated, as we can see in this slow-mo clip of the maneuver. Once the ILM flap is completed, we can document that the flap has been free from both temporal and nasal edges of the hole, and as a result of this, we can see a lifting of the hole edges, especially compared with the previous OCT images. Second case is a 70-year-old lady with a history of a failed vitrectomy for a full thickness macular hole. In this case, we can see the presence of drusen, which may be a factor that prevents hole closure. After staining with ICG and confirming no ILM was present, we followed to rough or mobilize the edges of the macular hole aided with a finesse or flex loop. After this maneuver, we use the intraoperative OCT to check the status of the edges adhesions. We can confirm there is still some tight adhesion at the temporal edge. With the use of a 38 gauge polytip cannula, we then try to induce a small localized detachment of the temporal retina in order to free the temporal adhesion. When and after the flow of BSS is injected through the 38 gauge polytip cannula, we can see that in the OCT that the temporal adhesions are free and the borders are mildly elevated. After this, we complete the surgery with a full air fluid exchange followed by a C3F8 gas, tamponade. The first week OCT under gas shows the macular hole, it's closed. Our last case is a high myop with progressive foveal schisis and decreased visual acuity, not an uncommon complication of pathological myopia. Partial vitrectomy and ILM peeling has shown in previous work to improve visual acuity. Nevertheless, macular holes can develop during surgery. Foveal non-ILM or foveal sparing ILM peeling may reduce this risk. During this case, we can see in the intraoperative OCT the small amount of foveal tissue and the defect in the inner segment and ardent segment junction, which is a biomarker associated with secondary macular hole formation. OCT can provide more visual information to the surgeon to guide ILM peeling without stressing the foveal area and also confirming or not the presence of a macular hole during the surgery. In these cases, visualization is usually challenging due to lack of contrast between stain and RPE. At the end of our peeling, we can confirm that the LM was peeled, sparing the fovea area without iatrogenic macular holes. The case is finished in standard fashion with an air fluid exchange and gas.